give you some insight on what we've been doing. Disclosures. Now, in the rotator cuff, the holy grail is probably the ability to improve tendon to bone healing with minimal morbidity and the maintenance of the muscle belly health. We know that there's fatty infiltration and atrophy within the muscle bellies of the rotator cuff, specifically supraspinatus and infraspinatus, and that has a significant impact on healing rate and function. But if we could find a way that was cost effective to improve tendon to bone healing, everybody would tend to use it. Now, why do we need an augmentation to a rotator cuff tendon repair? Now, you can find almost any study to support your position, but as you look at the vast majority of studies, everybody talks about a re-tear. I'd like to call it a non-healing event. You know, we all heard the patient who says, hey, the therapist tore my rotator cuff at 3 months when I started doing some strengthening. Probably that was not the case. It probably never healed, and that non-healing event probably occurs in the first 3 to 4 weeks after the surgery. Now, in small to medium tears, there's probably a 0 or 1 or 2% re-tear rate, non-healing rate to small, and into medium up to 35%. Now, when you get into large and massive tears, holy cow, the literature is all over the map. Anywhere from a 40% non-healing rate to a 90% non-healing rate, which was quoted out of a Yamaguchi study many, many years ago, but it only included 13 patients. The interesting thing is that we know the patient benefits from the surgery, even though there's a re-tear. Maybe the tear is not as big as the original tear. Maybe we've done a subacromial decompression, got rid of inflammation, whatever. However, it is clear in almost any study out there that better outcomes correlate with an intact rotator cuff tendon repair. But it's not just the tendon. The muscle belly is important. So trying to repair a tear that's irreparable or isn't going to function very well isn't going to make you look too good. So you need to get an advanced imaging study, either MRI or CT, to look at fatty infiltration and atrophy of the muscle bellies. You can see change in muscle pennation. And those changes tend to be progressive with a rotator cuff tear. Now, if you have a successful rotator cuff repair, we know that muscle, tendon, bone continuity is the best option. But it's not going to change or revert the fatty infiltration that has occurred in that muscle unit. Now, a successful rotator cuff repair might halt the atrophy in a percentage of cases, but it's weird in that it doesn't build the muscle back up. But patients, that muscle tends to function much better, but if there's significant fatty infiltration or atrophy, we know patients have some endurance and strength issues and some active forward elevation issues above horizontal, even in a successful repair. So, in large and massive tears, we have a higher non-healing rate. We know in some studies an open repair is better in the healing aspect than an arthroscopic repair. We know that an abduction pillow in a large and massive tear takes the tension out of the repair in a much better way than just a sling at the side. And fatty infiltration and atrophy are a little bit more prevalent in large and massive tears. So, can we improve that rotator cuff tendon healing rate? We know the first time is probably the best time. What's the timing of the repair? Let's do it before those muscle changes become significant. And here comes the kicker. Can we make it cost effective? And can we avoid complications? So I think we've all heard about biologics, tissue engineering, stem cells, gene therapy, many of those things. I mean, they're buzzwords all being thrown around. Let's break it down in rotator cuff stuff to mechanical factors. Load. You're going to repair a tendon, you're going to pull it back to the bone. How do you share that load? How do you hold that tendon in a secure repair to the bone. That suture tendon junction may actually be the weak link in the repair. That being said, though, whatever that construct is, we want to minimize gap formation between the tendon and the bone for a period of time for early healing. What if you have some type of biologic? You need that to be a scaffold for tendon integration. For a mechanical, you just can't put something on there that's inert and hope it's going to mechanically help. Then how do you upregulate the biologic stuff? Growth factors, matrix to hold those growth factors, whatever they may be, in place. Thus, improve the biologic potential of the tissues. But when you're talking about a rotator cuff repair, what tissues are we talking about? We're talking about the tendon and we're talking about the bone. How do we improve that healing rate? Suture tendon junction, we just talked about as the weak link. Remember, we're trying to put that tendon opposed to the bone. The problem is the two things as a surgeon you don't know, based even with age, gender, tear size, tear acuity or chronicity, MRI, fatty infiltration atrophy. The two things you do not know are tendon quality and tendon mobility until you get in there arthroscopically or surgically to determine that. Muscle atrophy, you're going to have a feel for with your imaging study, along with fatty infiltration or atrophy. So, can you enhance the things that you can change? Again, gene therapy, growth factors, augmentation patches, and then marrow stimulation. And of course, as time goes on and things change, if you look at the last 8 years of the literature, you know, it's just a swinging door on what the hot button is. Whatever you do with biologic enhancement or mechanical augmentation, it cannot be a bridge or gap filler, in my opinion, meaning, oh, look, the tendon doesn't come all the way back, so let's sew something between the tendon and the bone, or let's spray, you know, a fibrin clot in there and new tendon will miraculously appear. No, that's not going to happen. Now, probably the most common augmentation or biologic enhancement that we hear about in today is PRP, platelet-rich plasma. The theory has been, okay, we're going to spin this stuff down, we're going to concentrate these growth factors, and we're going to get improvement. And even if we don't get improvement, hey, it can't hurt. It can only help. Patients want it. They come to the office, they've been on the internet, and they want, you know, this magic fairy dust to improve their rotator cuff healing. And thus it's belts and suspenders. You know, you're going to do your normal technique, but let's add this and all will be well. Here's our problem though with PRP. There's a multitude of preparations differing. Is it leukocyte poor? Is it leukocyte rich? How much blood do you take to spin down to get how much? And then if it's 2 cc's or 3 cc's, how do you use it? Where do you put it? What preparation is best for a rotator cuff application? Hey, a ligament, like a medial collateral ligament strain in the knee might, or hamstring issue, a different PRP concentration or application might work for that. We just don't know. Where do you put it? Now, do you put it through an open approach, or do you put it through with the scope with the fluid still running and it all runs away? I mean, how do you get it to stay unless it's a fibrin clot? And then do you change your aftercare? Nobody really knows that answer. And here comes the biggie: cost versus benefit. You know, you hear about people getting PRP in there, or stem cells, or BMAC, bone marrow aspirate concentrate, into their knee or their shoulder for arthritis or rotator cuff issues. And we think it's magically going to create new tissue. There's an anti-inflammatory effect of that material. However, the cost can be anywhere from $700 to $1,700 out of pocket. Who pays for that? And is there a benefit? We don't know that yet. Now, rotator cuff repair and PRP, if you look at the literature, there's no peer-reviewed study that conclusively shows an outcome advantage to repair alone. There definitely documented better healing rates in some studies. The problem is the variability in technique, preparation, aftercare, the evaluation. Are they clinically better with patient-reported outcomes? What about the MRI? Is the tendon healing rate better? So it's all over the map, and that can be said for any other biologic preparation too. And then again, cost is not factored in for what incremental improvement you might have obtained. And again, I'll hit this again, re-tear. Did they re-tear it at 4 months or 6 months? Probably not. It's really a non-healing event. And that high failure rate may indeed be due to poor tissues and poor mechanical environment or poor biologic environment. So some of the early studies on tendon repair with a 90% non-healing rate might have been repairs on tendons that would have never healed anyway, a chronic massive rotator cuff tear. So biomechanics or biologics. Tendon to bone healing in the rotator cuff depends on biomechanical strength of the repair and the biologic factors that influence the healing. Now, most of the research over the last 20 years is focused on ways to improve mechanical strength of the repair. Anchors, sutures, suture configurations, transosseous equivalent, double row, triple row. I mean, you guys have all seen it. Now, maybe the race is to demonstrate an equal combination of biomechanical reinforcement or optimization and biologic reinforcement and optimization. But here we go. Where's the healing come from? Well, we know that torn rotator cuff tendon has very minimal cellular activity. And in larger tears at the edge of the tendon, it's even worse. So you've got to look at the bone, the blood, and the bone marrow cells. Maybe the majority of the healing potential comes from the bone side, not the tendon side. So how do we enhance that? Well, you need to stimulate the pluripotential cells of the bone marrow into the tendon-bone interface. Now we know that biologic enhancement of the footprint works. Now in the literature, it's been called marrow stimulation, cannulation, or channeling. It's not a microfracture. A microfracture is an awl that is a fairly, wedge-shaped device and kind of cracks the subchondral bone. Channeling or marrow stimulation or the nanofracture device is a uniform diameter, like 1 millimeter, and a uniform depth, usually somewhere in the 9 millimeter range. It promotes a positive biology at that footprint. You're not creating fractured bone and bleeding, you're creating a channel, hopefully, to that pluripotential bone marrow and those cells that come up. Now we know in studies that technique clearly improves rotator cuff healing. And I point out to you Milano's article in Arthroscopy 2013, Joe's article in Sports Medicine 2013, and Taniguchi in Shoulder and Elbow in 2015 as very good examples of that. Now, we know if we go back and say, okay, I got a 1 centimeter crescent-shaped rotator cuff tear. That tear probably doesn't need a lot of augmentation, doesn't need PRP, maybe doesn't need bone marrow stimulation. That tear is going to heal. That's going to have a 95% healing rate if you do the operation correctly, because it's a small tear. But a large and massive tear may be an ideal environment to help stimulate healing at the tendon-bone interface. Why? Larger tear, larger surface area to heal, larger stress strain on the repair. And as you can see in this MRI, I mean, if you look at the retraction of that tendon, it's all the way to the medial aspect of the acromion, there's going to be more tension on that repair. Now, what about footprint cannulation? The nanofracture device, it was developed really to try to stimulate pluripotential cells to repopulate cartilage defects in the knee. And it does that very nicely. But it also provides a very uniform access to the bone marrow of the footprint. It's a defined size. It does not create fractures or cracks in the surface. You access the marrow cells. It's reusable, and it's economical. Now, if you look at the pictures here, you see the nanofracture device coming in, and then if you look carefully, I don't know if my arrow is showing up here, but you can see the little cannulation holes here, and I'm going to show you that a little bit better later on. So the biology of the footprint, if you look at this video, look what's coming up out of the vents. As we put our anchor in, you're pressurizing the cancellous bone. Look at the marrow cells and marrow elements that are coming up out of the vent, if you will, in the footprint. Now, the rotator cuff is going to be laid right down on top of that. Now, I can't tell you that those nanofracture channels stay open for 3 hours or 3 days or 3 weeks, but clearly we have access to pluripotential cells at the tendon bone interface with this technique that you wouldn't get otherwise, even with scarifying the bone. Here we've lightly scarified the footprint. You do not want to remove the cortical bone. You want to remove the soft tissue and then use your nanofracture device. So again, here we see another metallic threaded anchor going in, and we've already nanofractured the footprint. Look at the marrow cells bubbling up from the vents. And then we're going to pull that tendon, obviously, over the footprint because the footprint is anywhere from 12 to 16 millimeters wide. So we've nanofractured, and I'll show you what my preferred technique is. It is relatively easy to do. It's percutaneous. It's economical. You do not have to change your surgeon's preferred repair technique. They can use any anchor or anchor configuration they want. It's arthroscopic. We know it has documented healing improvement, and it's cost effective. And hey, it's kind of fun. What I do, I use a herringbone pattern so that I'm staggering from medial to lateral, so I don't have a parallel line of holes from medial to lateral. Use the footprint cannulation. I usually start posterior because that's the hardest place to get to. And you can see on this image, that's a really big tear because you're looking at the whole back of the head over the top, and the little arrowheads show you, to the best of my ability, kind of that herringbone pattern going from medial or lateral to medial and back and forth as we move from posterior to anterior. And I use it in large and massive tears, or even a revision tear. In a small rotator cuff tear, 1 centimeter or less, 1.5 centimeters, I probably have not used it. I don't feel that it's necessary. Now, here we go. This is an intraoperative photo. On the left side, you can see our setup, and you see we're going to move the nanofracture device, and you'll see kind of some movement here as the stylet goes in down the channel, and then we're going to release what's called the thumble, that little white handle at the top to pull the needle back out of the bone. And again, this does not change how you do your technique. I put my anchors in percutaneously, and the nanofracture device typically goes in the same fashion. As you can see in the upper left-hand image, that's a beach chair position, and the nanofracture device is coming in right at the lateral border of the acromion. And here we go again. So you'll see me use the thumble to pull that back out. I apologize, I'm not synchronized here with the two videos. They'll get closer in a sec. And so you just kind of work, you can kind of even assess bone quality and bone softness in some of these things. And again, I'm trying to hit the footprint, and in a larger massive tear from moving posterior to anterior, I'm probably making 12 to 14 channels or cannulations. And here again, on the left, we see the anchor going in, again, percutaneously. You can see the marrow elements coming out of the nanofracture channel vents. And then on the right, you can see we've brought the tendon over that footprint, which, hopefully all those marrow cells are kind of coming up and filling that tendon bone interface. So bone marrow stimulation results, as we alluded to, Giuseppe Milano, large and massive tears, better healing rates. Joe, 124 patients with multiple channeling. Those who had the channeling had a re-tear rate of 22% at 1 year versus 45%. Exact same arthroscopic technique, they just didn't do the channeling. Taniguchi had 111 patients with chronic rotator cuff tears, age 64. So that's right in our wheelhouse, okay? By MRI, re-tear, bone marrow stimulation, 9%. Now, that's all comers. That's pretty darn good. With non-bone marrow stimulation, 24%. But take a look at the next line. Large to massive tears. Hard to believe that when he broke those out, he actually had, with bone marrow stimulation, a smaller re-tear rate or non-healing rate of 4.5%, and in the large and massive tears, non-bone marrow stimulation, 28%. So, hey, Taniguchi's doing something right? Even in his non-bone marrow stimulation, I think this shows our advancement in arthroscopic technique, 28% non-healing rate in large and massive tears. I think in the literature you're going to find that. That's going to be pretty typical in the 25 to 50% range, not the 90% range. But that's an amazing number, 4.5%. So clearly biologic enhancement works. So what's happening when you do this? Well, a study that just came out last month by Bilsel, what they did is they made chronic subscapularis tears in the rabbit, and then they went and did a nanofracture type of technique and repaired the subscapularis tear. Then they looked at strength and histology. So clearly the load to failure or strength to failure at 8 and 16 weeks was better on those that were nanofractured than those that were just repaired. And they also histologically looked, and they could see that there were thicker collagen bundles. So clearly something was happening at the bone tendon interface to create a more robust tendon bone junction, tendon bone healing. Now that's only 2 months and 4 months, but clearly shows that there is something going on structurally and biologically in that regard. So in summary, biologic enhancement, and let's call it tissue engineering, because who knows what that means, is an effort, though, that is here to stay. We're spending a ton of research dollars on it. And why? Well, rotator cuff repair since 1972 has been in the top 10 CPT codes in the United States. So it is one of the most common surgical procedures year after year after year, not just orthopedics, but throughout the country. There are many options, and they can be confusing. The cost to benefit analysis of some of the more sophisticated or involved materials is not yet clear. What is clear is bone marrow stimulation channeling or cannulation in large and massive tears significantly improves the healing rate. And if we remember back to the first slide, the Holy Grail is to try to improve tendon to bone healing in an economical fashion with low morbidity. So the goal is to have a healed tendon repair. So maybe more anchors, more sutures, more that is not the solution. Maybe better biology is the solution with the right repair technique. And if you compare marrow stimulation to PRP, PRP's probably been studied more, but that shows that it's incredibly equivocal. There are a couple studies on PRP that actually show the healing rate was worse with platelet-rich plasma. So we don't see that in marrow stimulation. It's not as studied as much, but clearly there is a positivity here that cannot be ignored. And the NanoFracture device is elegant because the handle is reusable. You have uniformity of what you're doing, and it's very applicable to rotator cuff footprint improvement. Now that's a fairly quick treatise, didn't get into a tremendous amount of biology, in a technical sense of things, but I think it gives you a very good framework on the what, the how, the why, and why it is a positive for a rotator cuff repair. I appreciate everybody signing in tonight.
Do you use NanoFracture on all cuff repairs?
I would tell you that I use it on large and massive tears, revision tears. As I said in the talk, if I've got a non-retracted small tear, and we've all seen them, you put the scope in and it's kind of hovering over the footprint. You don't need a lot of traction to get it to the footprint. I don't use the NanoFracture device. You could indeed, yes. It is a patient charge item. We're not sure, how that is actually handled. Every institution probably does something different. And some people say, well, I don't need the NanoFracture. I'm just going to take my awl and I'm going to pound it in. Again, if you do that, you're fracturing the bone, okay? And it may work, but I don't think it's nearly as reproducible and elegant. So I think in a small tear like that, you probably don't need to use it. But if you're getting into 2 centimeters, 2.5 centimeters and above, if there's some tendon quality, tendon mobility issues, yes, I think it's a wonderful way to enhance the biologic environment of the bone tendon interface.
Are you worried about anchor strength with your nano holes being so close?
It's a great question. I use, as you've seen in these videos, metallic threaded in anchors. Number one, they're cheaper than bioabsorbable or anything else. Also, I don't need to tap the bone because I'm putting the anchor in, so I get great bite. They're nitinol, so there's not a lot of scatter on the MRI, if at all. And Arthrosurface has done a study where they did a lot of channels in poor bone and then pulled on the greater tuberosity to see if there was a fracture risk, and there was not. I would imagine if you nanofractured the footprint and then came around the lateral side of the tuberosity and said, hey, I'm going to just make a bunch of cannulations to fill up the subacromial space with this material, and you've nanofractured on top and down the side, you might have an increased risk. But no, I'm not worried about my anchors pulling out. Now, obviously, in maybe female bone over the age of 65, again, that's why I use metal anchors. That can happen to anybody, but no, I have not felt the risk there. And remember, the NanoFracture is a 1 millimeter needle, if you will, that is uniform and goes 9 millimeters deep. So you're not cracking the surface with a wedge-shaped awl.
And do you burr the footprint at all?
What I do is I try to get rid of all the soft tissue. And then I've stopped using a burr. I'll use like an aggressive shaver, maybe to do what I call scarify the cortical surface. But I don't want to see cancellous bone for the most part. I want to see maybe some punctate bleeding or scratch on the cortical surface, then I nanofracture.
Is there anything specific in your technique that has evolved over time that could help us ensure future users a positive experience immediately?
Obviously, you're using this in a large and massive tear, more than anything else. So you're going to have potentially some posterior superior rotator cuff involvement. In these large and massive tears, I typically will put them in a sling with a derotation wedge, meaning a triangle. So they're more in a handshake type of position. And I go slow with their therapy. May start them with pendulums at a week, but I probably won't refer them to formal physical therapy for 3 weeks because it's a large and massive tear. You're already up against the size, mechanics, and biology, and your goal is a healed tendon. So for me, I think it's a go slow option in therapy, and positioning is key. Now, there are not a lot of slings out there that allow you that neutralization or derotation position. I've used one for 25 years of my practice that I have either made myself or a company's made for me. We now have one called the Versa Sling. It has the typical rectangular pillow, but that rectangular pillow is made out of 2 triangular pieces. So if you unvelcro them and flip them around, it turns into a triangular wedge. So the patient is now in a handshake position. And I think that takes the tension off the posterior rotator cuff and clearly actually has been shown to take a twist or strain off the supraspinatus, even in a model compared to a sling. It sounds funny that the anterior aspect of the supraspinatus would be under less twist or tension in a handshake position than in a classic sling position across the tummy, but it is. So for me, I would say go slow in physical therapy and don't discount sling or immobilization position as adjuncts to success. And I guess what I would tell you in large and massive tears, everybody has a different technique or suture technique or repair technique based upon the type of anchors they use and what company provides them. So in these tears, typically I am using a double row type technique or transosseous equivalent type technique so that there's a medial point of fixation and a lateral point of fixation. So in between those two is the rotator cuff, and that's the footprint. And hopefully underneath that, in that 12 to 14 to 16 millimeter footprint, is all those nice marrow cells. So large and massive tears, double row type technique, which some people would call transosseous equivalent, go slow with therapy, and sling position is not inconsequential.
Thank you. And have you seen any re-tears or non-healing after NanoFx augmentation? If so, in what type of tear?
It's a great question, and I'll be very honest, we have not studied our patients in a systematic fashion with ultrasound or MRI yet. We've been talking about it now for about a year. We were going to get really sophisticated. We were going to take assays of the subacromial space after we did the nanofracture. We were going to send it off and get growth factors and, IL 3000 and interleukin this and TGF beta 1,000,000. And it's really, really difficult and really hard. So I really can't answer that one. I would probably refer you to the studies I mentioned. Now, anecdotally, those patients that I have done, even their pain level seems to be a little bit less. You know, you'd think, okay, hey, wait a minute, I'm hammering a needle in the bone, they're going to have more bleeding, they might have more pain. I don't know if we're releasing substance P and things like that from the bone, but they tend to have less pain. Maybe that's because my immobilization and a little bit of a go slow. But anecdotally, you really look at those patients very, very, you know, skeptically because they are larger. You do go slower, but boy, they have really done well. And so I can't answer your question in my own practice. I need to do a better job on that, but we tried to set up the study a couple times. It's just run into some logistic issues. Thank you, everybody. I hope everybody has a good evening. Aislinn, thank you so much.